So let's transition to the GC agonists. Tony, let's start with linaclotide, and then we'll move on to plecanatide, and then we'll argue about which has less diarrhea, because that's always the argument. But start with linaclotide as the first one, again, out the gate, as you said.
Sure. So it was the first of two GCC or guanylate cyclase-C agonists. These are receptors that are on the lining of the GI tract, so right from the antrum right down to the distal colon. Most of the effect is probably likely to be prostrone in the small bowel. And by stimulating the GCC, it has a second messenger, cyclic GMP, which turns out to be important because it does two different things, as far as we know from at least animal models. It opens up the CFTR, or chloride channel, and it also may affect the afferent nerves in the submucosa or other linings of the GI tract, thereby reducing abdominal pain. Linaclotide is a product that is taken once a day, and it comes now in three different doses: 72, 145, and 290 micrograms. Though the lower doses are for constipation, and the higher dose is for IBS with constipation. That's at least the FDA-approved doses. But in clinical practice, we'll use a variety of different doses with it. And in the clinical trials, it shows that it improves abdominal pain, which is key, bloating, as well as stool frequency and consistency. One of the issues with linaclotide is that it can cause diarrhea, and sometimes it can be severe. So I usually
think that's part of the reason they went to lower doses, right? To try and get under the diarrhea. Am I wrong in that?
So that's correct. The data with the lower doses, of course, 72 was studied in chronic idiopathic constipation, didn't actually show less. But in clinical practice, I think I think I see less. Importantly, I tell patients that this could happen. I think if you prep the patient for it, let them know that first couple times they take it, to be aware that that could happen. Don't plan it when they're about to take a long trip or anything. That it's less of an issue with patients. And yeah.
So Bill, plecanatide, the contrasting agent, not really contrasting, it's the same category.
Yeah, absolutely, and a very similar agent, also a GCC agonist, so works by a similar mechanism to what Tony talked about. And like linaclotide, there are large phase 3 studies showing benefits for chronic idiopathic constipation and IBS-C, and it's approved for both indications in the United States. The diarrhea rates, the main side effect with linaclotide is diarrhea, and as Tony mentioned, around 20% of the patients in the clinical trials. And lower rates of diarrhea were reported in the plecanatide trials, but there's a lot of, as you alluded to, Mark, there's a lot of controversy as to how that data was collected. I'm not sure I'm the best person to comment on, on that particular issue. But what I would say, just from a practical standpoint, is I think they're both very effective drugs, and I also, by the way, think they're both very safe. We've done some work, which I think is quite interesting, showing that regardless of whether you're talking about a GCC agonist or other forms of treatment for constipation, that most patients who are constipated actually don't mind having some loose stool. So they don't view it as an adverse event.
Well, this goes back to quality of life a little. There's studies that show that the quality of life of DIBS patient versus C, doctors are threatened or enthusiastic about working up diarrhea, and they want to do. And when they see a constipated patient, they're like, oh, constipation. But the patients are more miserable in the constipation category than they are in the diarrhea category because they never get relief. So, Brendan, should we not worry? Diarrhea doesn't matter. Let's get them relief because they're quite miserable.
Yeah, no, I think you're onto something with this. Literally urgency, right, requires sort of like an urgent workup in the mind of the physician, whereas constipation is slow, we could take our time. But, it's sort of facetious, but not. I mean, you're right. I think doctors are maybe a little more laissez-faire about take a laxative. And I think it's important, again, to distinguish. We're talking about IBS-C here. We're talking about not just moving bowels, but also reducing the bloating and the discomfort. And that's all part of why the quality of life is so affected in IBS-C and in IBS-D. For slightly different reasons. So no, I think we need to be just as aggressive at improving quality of life in these patients as we would in IBS-D patients.